Think about it. Your heart pumping blood, your kidneys filtering, your nerves carrying signals. They seem like separate jobs, right?
Mm-hmm.
But when we're talking about something like vascular surgery, a procedure on your blood vessels, it's like tossing a pebble in a pond. The ripples spread everywhere.
That's a perfect analogy, yeah. And those ripples, the potential complications that can arise after vascular surgery, are exactly what we're diving deep into today.
Okay.
We've gathered insights from a really comprehensive book, Rutherford's Vascular Surgery and Endovascular Therapy, to give you, the learner, a clear and efficient understanding of what you need to know.
Okay, let's unpack this, because it's not just about the blood vessel the surgeon is working on, is it?
Not at all.
We need to be aware of potential issues with your heart, your kidneys, nerves, the graft itself, if one is used,
Right, the graft.
the risk of infection, and even something called a secondary aortoenteric fistula.
Mm-hmm.
Sounds quite serious.
It can be, yeah.
It might sound like a lot, but we'll break it down into the key insights, drawing on the deep knowledge within these medical chapters.
Precisely. Consider this your streamlined guide to understanding the broader impact vascular surgery can have. We're focusing on the essentials without getting bogged down in, overly technical details.
Good. So let's get right to it, starting with the organ that keeps everything going.
Yeah.
The heart. Cardiac complications are a major concern.
Mm-hmm.
And one thing that really stood out in our sources is this idea that it's not just about the specific blood vessel problem, as one source put it. It is not the kind of disease the patient has, rather the kind of patient that has the disease. What's the key insight there?
Well, what's fascinating, or maybe concerning, is how often patients with vascular problems also have a number of risk factors for heart disease. Think of things like high blood pressure, diabetes, maybe previous heart issues. This underlying vulnerability combined with the stress of surgery.
Yeah, the surgery itself is a stress.
Huge stress. These significant shifts in blood pressure and blood flow, we call them hemodynamic changes, plus changes in the body's clotting system. Well, it can unfortunately create the perfect conditions for what doctors call Perioperative Major Adverse Cardiac Events, or MACE.
MACE.
MACE is essentially a collection of serious heart-related problems that can happen around the time of surgery.
And what are the most common of these MACE events? What are we really looking out for?
The most frequent is a myocardial infarction, or MI, that's a heart attack.
Right.
Following that, we see atrial fibrillation, which is an irregular heartbeat, and acute heart failure, where the heart just can't pump enough blood.
Okay.
Now, it's really important to understand that the risk of these events isn't the same for everyone. It truly depends on the specific type of blood vessel surgery being done, why it's necessary, and how urgently it needs to happen.
But we're talking about pretty significant risks in some situations, right? Not trivial.
Absolutely. For major procedures like a lower extremity bypass, that's to improve leg circulation, or an aortofemoral bypass for abdominal aorta issues, and repair of an abdominal aortic aneurysm, that's a bulge in the main artery in the abdomen.
The AAA repair, yeah.
Right. For those, the expected rates of MACE can range from around 10% to over 20%.
Wow.
And the risk of death can be between 2% and 3%. That really highlights why understanding the underlying mechanisms is so important.
Okay, so let's talk about these MIs, or heart attacks. Our sources get into the nitty-gritty, even mentioning something called the universal definition of MI. Can you simplify that for us? What's the takeaway?
Certainly. Think of the universal definition as a way doctors worldwide agree on what counts as a heart attack. The latest version from 2018 helps us distinguish between problems where the heart muscle is actually damaged due to a lack of blood flow, that's a true myocardial infarction, or MI,
Got it.
and situations where there's heart muscle injury for other reasons. Within MIs, there are different types, but for our discussion after vascular surgery, types I and 2 are the most relevant. Type I is what we traditionally think of as a heart attack, often caused by, a blood clot blocking an artery in the heart.
The classic one.
The classic one. Type 2, on the other hand, is often due to an imbalance between the heart's need for oxygen and the amount it's actually getting, a supply-demand mismatch.
Supply and demand that makes sense in the context of surgery, where blood pressure and, well, everything can fluctuate, right?
Exactly. And then there's a newer term you might hear: myocardial injury after non-cardiac surgery, often shortened to MNS.
MNS.
Yeah. While our source notes this can sometimes overlap with the universal definitions, the key takeaway is that even a significant rise in high-sensitivity cardiac troponin.
It's the blood marker.
That's the marker in the blood that indicates heart muscle damage, yes. A rise in that after any surgery that's not on the heart itself is a serious sign.
Okay.
It happens in a notable number of patients and is linked to much higher rates of death.
So it's not just about a full-blown heart attack. Even just seeing that heart damage marker go up is bad news.
Precisely. For example, if troponin levels go above a certain threshold, like 1,000 nanograms per liter, studies have shown a nearly 30% chance of death within 30 days.
30%, wow.
What's really striking is that elevated troponin is even more common after vascular surgery. It affects about 1 in 5 patients.
1 in 5.
And it dramatically increases the risk of death within 30 days, making it 8 times more likely.
8-fold increase.
Yeah. So the crucial insight is that any significant rise in troponin after vascular surgery, even if it doesn't fit the classic definition of a heart attack, is a major red flag for increased mortality.
Wow, that's a sobering statistic. What about congestive heart failure, CHF? How does that play a role?
Congestive heart failure, or CHF, whether it's present before, during, or after surgery, adds another layer of risk. It makes sense, right? Patients who already have heart problems are especially vulnerable to the fluid shifts and potential stress on the heart that can occur around the time of surgery. Research has shown that developing CHF during or after surgery can significantly increase the risk of dying. By quite a bit, actually, like 63% increase in operative mortality.
And does it matter if it's heart failure where the pumping function is still okay versus when it's reduced? Preserved versus reduced ejection fraction?
It does seem to. There's some evidence suggesting that patients whose heart can still squeeze effectively, that's preserved ejection fraction, or HFpEF,
Okay.
they might do somewhat better than those whose heart muscle is weakened, reduced ejection fraction, HFrEF. In those cases, the degree of weakness seems to correlate with worse outcomes.
Makes sense.
And specifically for vascular surgery patients, having CHF before surgery has a big impact. For instance, patients with CHF undergoing a bypass in their leg below the groin have more than 2-fold increase in their risk of dying within 30 days.
2-fold.
And they tend to stay in the hospital longer, too.
Given these significant heart risks, what's the typical approach then? How do you check patients for pre-existing blockages in their heart arteries before they undergo vascular surgery?
Well, we know that a large majority of vascular surgery patients, maybe around 90%, have some underlying coronary artery disease. Their heart's arteries might have some narrowing or blockages.
90%, that's huge.
It is. So it's important to identify those with severe, potentially silent blockages. However, we don't routinely put everyone through extensive heart testing. It's not necessary or efficient.
Okay.
The current thinking is that for lower risk procedures in patients who don't have any heart symptoms or whose symptoms are stable, we generally don't need to do cardiac imaging stress tests, which look at how the heart performs under stress.
But for those who do need a closer look, there are different imaging options, right? Like SPECT, CMR, and FFRCT. Can you give us a quick rundown?
Certainly. Sepstecta, or single photon emission tomography, is widely available, commonly used. It gives us reproducible pictures of blood flow to the heart. Downside, it does involve some radiation exposure. Cardiac magnetic resonance imaging, or stress CMR, uses powerful magnets and radio waves. Creates detailed images. It's been shown to be very good at detecting significant blockages, sometimes even better than SPECT. Plus, it gives us info about the heart's structure.
But limitations.
Yeah, can't be used in patients with severe kidney problems or certain types of implanted devices like some pacemakers.
Got it. And FFRCT.
FFRCT, or fractional flow reserve CT coronary angiography, this is newer, non-invasive, uses a regular CT scan of the heart arteries, then applies computer analysis to estimate how much a narrowing is actually affecting blood flow.
Ah, so it tells you if the blockage matters.
Exactly. It's a really exciting development because it can help determine if a blockage is severe enough to warrant treatment without needing to do an invasive procedure first.
That sounds promising. And what about going straight to a coronary angiogram, putting a catheter into the heart arteries, and maybe doing a procedure like stenting or bypass surgery before the vascular surgery? Does that help reduce the risk?
That's a really important question, and the way we think about this has actually changed over time. Some earlier studies suggested it might be helpful, but a major study called the CRP trial back in 2004,
Okay.
it actually showed that for most patients undergoing major vascular surgery, doing preemptive heart artery procedures like stenting didn't lead to better outcomes, didn't reduce ME.
Really? So fixing the heart first didn't help the vascular surgery outcome?
For most, no.
Yeah.
So Current guidelines now recommend doing those heart procedures before non-heart surgeries only when they are clearly indicated based on established guidelines for treating heart disease itself,
Okay.
not just routinely to try and prevent heart events around the time of the vascular surgery.
So the focus shifts more to managing risk with medications and good general care then.
Exactly. Things like beta blockers, statins, and aspirin are key.
Right.
For patients who are already taking beta blockers, it's strongly recommended, class I indication, that they continue them.
Don't stop them.
Definitely not. Starting beta blockers in high-risk patients who aren't already on them. Well, it may be reasonable, level 2A evidence suggests.
Okay.
Statins, which help lower cholesterol, are generally recommended. Continue those. And continuing aspirin, if the patient is already taking it, is also advised.
What about newer blood thinners, like if someone has a recent stent?
Good question. For patients who have had a recent coronary stent placed, say, within the last 6 months, it's important to continue medications that prevent blood clots in the stent, the dual antiplatelet therapy.
Right.
But this decision needs to involve a team of doctors, cardiologists, surgeon, anesthesiologists to weigh the risks of bleeding during surgery against the risk of the stent clotting off.
Makes sense. A balancing act. What about things that happen during the surgery itself? Are there factors there that can increase the risk of MC?
Yes, several things come into play. The type of anesthesia used, the amount of blood lost, and whether a blood transfusion is needed.
Transfusions aren't risk-free either.
No, they aren't. And how carefully blood pressure is managed is crucial. There's even research linking significant drops in blood pressure during surgery, intraoperative hypotension, to a higher risk of adverse events.
So keeping the pressure stable is key.
Very key. Body temperature during surgery is another factor. While the evidence is maybe somewhat mixed, current recommendations suggest trying to maintain a normal body temperature, what we call normothermia.
Especially for big surgeries.
Especially during aortic aneurysm repair. Yes,
I'll say.
the SVS guidelines recommend it.
And then the period right after surgery is also critical, isn't it? The immediate recovery.
Absolutely. That postoperative period is really high risk. Patients go through significant changes in their body's physiology, their fluid balance, their blood flow in the early hours and days after surgery.
A lot going on.
A lot. And this can sometimes hide developing heart problems. We see a surprisingly high rate of what we call silent ischemia, meaning reduced blood flow to the heart without obvious symptoms like chest pain.
Silent.
And that myocardial injury, the MINS we talked about after vascular surgery. That's why it's so important for doctors and nurses to be vigilant, to have a high index of suspicion, a low threshold for ordering an electrocardiogram, ECG, and checking those troponin levels if there's any suspicion of a heart issue.
Better safe than sorry.
Definitely. Unfortunately, if patient does develop congestive heart failure after surgery, it often has a poor long-term outlook, which highlights the need for early involvement of specialists in heart failure management if it occurs.
Okay, that's a really thorough look at the cardiac side. Let's shift gears now. Moving on from the heart to another absolutely vital organ system, the kidneys. They do so much to keep our bodies in balance.
They truly do. The kidneys are, the main regulators of the amount of fluid in our bodies and the balance of salts and other substances in our blood.
Like the body's filter system.
Exactly. They do this through an amazing process of filtering the blood, that's glomerular filtration, and then carefully adjusting what's kept and what's removed through tubular secretion and reabsorption. They get a huge amount of blood flow from the heart, filtering a massive volume of plasma every single day. Just incredible organs.
And what kind of kidney problems might we see after someone has vascular surgery? What are the warning signs?
The most common signs are a decrease in urine output, which we call oliguria.
Less pee.
Right, less pee. And an increase in the levels of creatinine in the blood. Creatinine is a waste product that healthy kidneys filter out, so rising levels can indicate a problem.
Okay.
The causes of kidney trouble after surgery can be broadly divided into 3 categories: pre-renal, renal, and post-renal.
Pre-renal, post.
Pre-renal issues, which are the most common early on, are usually due to things before the kidney, like dehydration or the heart not pumping well enough, reducing blood flow to the kidney.
Okay, not enough flow getting there.
Exactly. Renal causes involve direct damage to the kidneys themselves. This could be from reduced blood flow during surgery ischemia or exposure to certain medications or contrast dyes used in imaging.
Ah, the contrast dye issue.
Right, or a condition called acute tubular necrosis, ATN, where the kidney tubules themselves get damaged.
And postrenal.
Postrenal causes are due to a blockage after the kidney in the urinary tract, preventing urine from flowing out, like a blocked catheter or something pressing on the ureters.
Reduced blood flow to the kidneys during surgery seems like a particular risk in vascular procedures where blood vessels are being clamped, doesn't it?
That's absolutely right. When blood flow is reduced ischemia and then restored reperfusion, the cells in the kidney tubules can actually swell up.
Swell.
Yeah, and this swelling can potentially block the tiny tubules inside the kidney and further reduce the kidney's ability to filter waste. It's a complex injury process.
And is it possible to block the main renal artery itself?
It is. A complete blockage of a renal artery, whether from a clot or surgical issue, can lead to either a sudden, acute decline in kidney function or a more gradual chronic one. We call that ischemic nephropathy.
And what about those contrast agents used during some vascular imaging procedures, angiograms and CT scans? We often hear about contrast-induced nephropathy or CMIN.
Yeah, CMIN is a real concern, especially in patients who already have some kidney problems or have diabetes or are dehydrated going into the procedure.
So how do you minimize that risk?
Well, doctors will often recommend giving intravenous fluids hydration before and after the procedure to help flush the contrast out of the kidneys. And they'll try to use the lowest possible amount of contrast needed to get the images. It's about balancing diagnostic need with risk.
Aortic surgery, operating on the body's main artery, seems like it could have its own specific risks for the kidneys. We touched on fluid shifts earlier.
Yes, absolutely. The significant fluid shifts that can happen during major aortic surgery are a big deal for the kidneys. This includes what we call third spacing.
Third space.
That's where fluid moves out of the bloodstream and into the surrounding tissues, like the bowel wall or under the skin. This can significantly reduce the amount of circulating blood volume, even if fluids are being given.
So the patient looks swollen, but the kidneys aren't getting enough flow.
Kind of, yeah. It can put major stress on the kidneys. This requires very careful, very meticulous management of fluids by the anesthesia and surgical team.
And the clamping.
Right. Additionally, surgery on the aorta, especially when it involves clamping the aorta above the arteries that supply blood to the kidneys, what we call suprarenal clamping.
Above the renal arteries.
Yes, that carries a higher risk of postoperative kidney failure. For repairs of aneurysms in the part of the aorta that runs through the chest and abdomen, thoracoabdominal aneurysms, this risk can be quite substantial, maybe up to 18% in some series.
18%.
And if acute kidney failure does occur after these major aortic surgeries, it's unfortunately associated with a very high mortality rate.
So what are the main things surgeons do to try and protect kidney function during these big aortic operations?
The key strategies involve, first, trying to minimize the amount of time the kidneys are without a full blood supply during the procedure, minimizing that ischemia time.
Keep the clamp time short.
As short as possible, exactly. Making sure the patient is well hydrated with intravenous fluids before surgery. Replacing any lost blood volume effectively during and after the operation, and trying to avoid repeated or prolonged interruptions of blood flow to the kidneys.
Like clamping and unclamping multiple times.
Right, repetitive ischemia can be particularly damaging. Making sure the heart is functioning as well as possible is also crucial because good cardiac output helps kidney perfusion.
Chronic kidney disease, CKD, is also something that needs to be considered in these patients, I imagine.
Absolutely. Chronic kidney disease is a long-term condition where the kidneys aren't functioning properly. It's classified based on GFR, the glomerular filtration rate, how well the kidneys filter waste, and the amount of protein, specifically albumin, in the urine. The presence and severity of CKD can significantly increase the risk of developing acute kidney problems after vascular surgery. These patients just have less renal reserve.
Makes sense. Does the surgical technique itself play a role beyond clamp time?
It can. For example, as we mentioned, avoiding repeated clamping of the aorta can help reduce the risk of tiny particles like bits of plaque breaking off and traveling to the kidneys, a process called microembolization.
Showering the kidneys with debris.
Potentially, yes. Also, in some cases during aortic surgery, the left renal vein might need to be divided to get better access to the aorta.
Cut the vein.
Temporarily divide it, yes. While the body usually compensates with other veins taking over the drainage, it's something surgeons consider carefully and try to avoid if possible, or repair if necessary.
And if acute kidney failure does occur after surgery, despite all the precautions, what's the treatment?
The initial treatment focuses on supporting the patient. This might include restricting fluids because they can't pee it out effectively.
Right.
And using medications called diuretics like furosemide to try and help the body get rid of excess fluid and maybe kickstart the kidneys.
But if that doesn't work?
In more severe cases where the kidneys really can't filter waste effectively and waste products build up, then dialysis becomes necessary.
Dialysis.
Either hemodialysis, where blood is filtered by a machine outside the body, or peritoneal dialysis, where fluid is put into the abdomen to filter waste across the peritoneal membrane. It's a way to support kidney function while they hopefully recover.
Okay, let's move on. Our bodies rely so much on our nervous system, and it's interesting, maybe not surprising, to think about how vascular issues or the surgery itself can sometimes lead to neurological problems.
It's definitely something we need to be aware of. We often see a general condition called peripheral neuropathy in patients who have poor circulation due to vascular disease, especially in the legs.
Like numbness and tingling.
Exactly. Numbness, tingling, burning pain in the extremities. That's often from the underlying disease. But we also need to consider specific nerve injuries that can happen during the surgical procedures themselves.
For example, during surgery on the carotid artery in the neck, the one supplying the brain, there's a risk to certain nerves in the head and neck, right?
Yes. Procedures involving the carotid artery, like a carotid endarterectomy where plaque is removed.
Cleaning out the artery.
Right. Those can potentially injure some of the cranial nerves. These are the nerves controlling functions like facial movement, swallowing, voice, and tongue movement.
Okay.
Data from a large study called the CREST trial showed that about 4.6% of patients who had a carotid endarterectomy experienced a cranial nerve injury.
Almost 5%. This is usually permanent.
The good news is that in most cases, these injuries resolved within about a year. But it can be distressing while it lasts. The vagus nerve, which affects voice and swallowing, and the hypoglossal nerve, which controls tongue movement, are among those most commonly affected.
And what about surgeries in the upper chest and neck area? Maybe for subclavian artery problems or accessing vessels there?
Absolutely. Surgeries in the area above the collarbone, the supraclavicular region, and those involving opening the chest to thoracotomy can potentially injure other important nerves.
Like which ones?
Like the phrenic nerve, which is crucial for breathing because it controls the diaphragm muscle. Injury can cause shortness of breath.
Okay.
The long thoracic nerve, which affects the serratus anterior muscle, important for shoulder blade movement and raising the arm injury, causes a winged scapula. And the intercostal nerves, which run between the ribs. They're involved in breathing mechanics and provide sensation to the chest wall. Injury can cause pain or numbness.
What about the nerves in the arms and legs? They seem particularly vulnerable during some vascular procedures in those areas, maybe due to positioning or retractors.
Definitely. Let's start with the arm. The brachial plexus is a complex network of nerves in the shoulder and upper arm.
The big bundle.
The big bundle, exactly. It gives rise to all the major nerves of the upper extremity. Things like fractures, collections of blood called hematomas, putting pressure on the nerves.
Hematomas again?
Yes. And even just the way a patient is positioned on the operating table for a long time can sometimes stretch or compress these nerves and cause injury.
So positioning is really key.
It is. And if a hematoma is compressing a nerve, it's really important to diagnose that and relieve the pressure quickly, surgical decompression, to prevent permanent damage.
And specific arm nerves.
Specific nerves like the median nerve, think carpal tunnel, the ulnar nerve, the funny bone nerve, and the radial nerve, controls wrist and finger extension, can all be at risk during various surgical procedures in the arm, forearm, or wrist, depending on the approach.
And similarly in the legs, the lumbosacral plexus.
Exactly. The lumbosacral plexus is the equivalent network of nerves in the lower back and pelvis that supplies the legs and feet. It has its own blood supply, which can sometimes be compromised.
Ah, so ischemia can affect the nerves too.
It can. And nerves, like the lateral femoral cutaneous nerve injury, causes numbness on the outer thigh, neuralgia peristatica.
Okay.
The femoral nerve, quadriceps muscle, sensation front of thigh, the sciatic nerve, the big one down the back of the leg. The common peroneal nerve wraps around the fibula head, risk of foot drop if injured.
Foot drop, right.
The tibial nerve, muscles in the calf, sensation sole of foot. And the sural nerve, sensation outer ankle foot. All these can potentially be injured during lower extremity surgery.
Ow. Same reasons. Retractors. Positioning.
Often, yes. Surgical instruments called retractors pulling on tissues, prolonged awkward positioning, direct injury during bisection, or hematomas causing compression. It leads to a range of problems with sensation and muscle function depending on the nerve involved.
There's also the sensitive topic of sexual dysfunction after some types of vascular surgery, particularly aortic surgery.
Yes, that's an important consideration and something patients should be counseled about, especially before surgery on the aorta and the iliac arteries in the abdomen and pelvis.
Why does that happen?
It's often due to injury to a network of nerves called the superior hypogastric plexus and the hypogastric nerves themselves. These nerves run close to the aorta and iliac arteries and are involved in controlling erection and ejaculation.
Okay.
Injury can lead to erectile dysfunction, or ED, in men, and also problems with ejaculation, specifically retrograde ejaculation, where semen goes backwards into the bladder instead of out of the penis during orgasm.
Can surgeons prevent this?
Surgeons take specific steps during these procedures to try and minimize this risk. They try to carefully dissect and preserve these nerve structures, sometimes making an effort to keep them intact on at least one side of the body if possible.
Does it still happen often?
It still occurs. And interestingly, sexual dysfunction is also reported quite commonly after endovascular aortic aneurysm repair, EVAR, the stent graft procedure. The exact reasons there might be different, maybe related to blood flow changes or other factors, but it's a known potential side effect for both open and endovascular repairs.
Okay, so far we've talked about the body's own systems, heart, kidneys, nerves. But what about the artificial components that are sometimes introduced during surgery, the grafts? They can have their own set of problems, can't they?
Absolutely. Grafts, which are basically artificial blood vessels used to bypass blockages or repair damaged arteries, are fantastic tools, but they can unfortunately develop problems. The main ones are thrombosis, which is the formation of a blood clot inside the graft.
Clotting off.
Right, clotting off. Or they can become infected, which is a very serious complication.
How do you monitor grafts after surgery?
Ultrasound imaging plays a really important role, both sometimes during the surgery itself to check the connections, and definitely for monitoring the graft over time, long term.
What kind of ultrasound?
We use both standard ultrasound, called B mode, which gives you the picture, and Doppler ultrasound, often together as duplex ultrasound. Doppler looks specifically at blood flow, how fast it's moving, if it's smooth or turbulent.
So you can see if it's narrowing or clotting.
Exactly. It helps assess the structure of the graft and how well blood is flowing through it. Duplex is pretty good. Its sensitivity and specificity compare reasonably well to traditional arteriography, the dye test. But standard B mode alone can sometimes have limitations, like distinguishing a fresh, soft blood clot from blood that is just moving very slowly.
Okay. Let's talk about graft thrombosis, the clot. You mentioned it can happen early on, after surgery, or much later. What are the main differences there? Why does it happen at different times?
That's right. We usually classify it based on time. Early graft thrombosis, which happens within the first 30 days after surgery.
Okay, the first month.
That used to be primarily blamed on technical errors during the operation itself. Maybe a kink in the graft, a bad connection, something like that.
Makes sense.
However, with advances in imaging techniques used during surgery, like angioscopy looking inside the vessel with a tiny camera and intraoperative duplex ultrasound, the number of early graft failures caused purely by technical issues has thankfully gone down.
It's good. So what causes early failure now?
Now, early failure is often more related to other factors. Maybe the quality of the patient's own blood vessel that was used to create the graft, if it was a vein graft, or problems with the runoff, the blood flow further down the leg beyond the graft. If there's poor outflow, the graft can thrombose.
Okay. And late graft failure after 30 days.
Late graft failure, which occurs more than 30 days after surgery, can be caused by a variety of factors.
Right.
Sometimes it's related to the graft material itself, especially synthetic grafts, which can be more prone to clotting over time.
Right.
More often, it's due to the ongoing progression of atherosclerosis, the artery disease in the patient's own vessels, either just before or just after the graft connection points. This can cause narrowing, reducing flow through the graft.
So the underlying disease catches up.
Exactly. Or sometimes issues with blood flow dynamics, maybe low flow states. There's a whole classification system based on the timing, the likely cause, and how you might treat it.
And when a graft does fail, are there certain things that might suggest the patient is likely to need more interventions or procedures down the road?
Yes, studies have looked at this. Factors like being younger at the time of the first surgery.
Younger. That seems counterintuitive.
Well, possibly because they have more time for the underlying disease to progress, or maybe the disease is more aggressive. Also, having diabetes, having pre-existing coronary artery disease, and having significantly reduced blood flow in the opposite leg as measured by something called the ankle brachial index, or ABI. These have all been linked to a higher chance of needing further procedures after an initial revascularization.
Okay. And if the best option for a bypass, the patient's own great saphenous vein in their leg, isn't available or suitable, what then?
That's a common problem. If the ipsilateral same-side great saphenous vein, GSV, is unavailable, maybe it was used for heart surgery already, or it's diseased. Surgeons have to get creative.
What are the alternatives?
Options include using veins from the arm, the cephalic or basilic veins. Sometimes shorter segments of veins can be pieced together, creating a spliced vein graft. In some situations, cleaning out the patient's own deep femoral artery, the profunda femoris, or the superficial femoral artery, SFA procedures called endarterectomies, might be an option instead of a long bypass graft. Each of these alternative conduits or strategies has its own potential advantages and disadvantages in terms of durability and suitability.
Okay. Let's shift to graft infection. You mentioned it's serious. We're hearing more and more about antibiotic-resistant bacteria like MRSA, making these infections harder to treat.
Absolutely. Graft infection is one of the most devastating complications in vascular surgery. And yes, the number of vascular graft infections caused by methicillin-resistant Staphylococcus aureus, or MRSA, has definitely been increasing. These infections are very challenging to treat because MRSA is resistant to many commonly used antibiotics.
Is it just MRSA?
No, other types of bacteria are also frequently involved in infections at vascular surgical sites, VSSIs, gram-negative bacteria, other staph species, Enterococcus. It can be a mix.
So prevention must be key. What are the main principles to minimize these infections?
Prevention is paramount. There are several key steps. Keeping the hospital stay before surgery as short as possible reduces exposure to hospital bacteria.
Get in, get operated, get out.
Ideally, yes. Having patients shower with antiseptic soap, like chlorhexidine, before surgery helps reduce skin bacteria. Making sure any other infections the patient has, like a urinary tract infection or skin infection elsewhere, are under control before the vascular surgery.
Treat other infections first.
Yes. Carefully removing hair from the surgical area, clippers are preferred over razors now to avoid skin nicks. Meticulously protecting the graft during the operation from contamination, avoiding doing other types of surgery, particularly on the bowel or contaminated areas, at the same time as the vascular procedure, if at all possible.
Don't mix clean and dirty cases.
Exactly. Giving prophylactic antibiotics intravenously just before the surgery starts is standard practice, and specific steps to control MRSA, such as screening patients for MRSA carriage in some centers and using contact precautions for known carriers, are also becoming increasingly important.
How do doctors diagnose a graft infection if they suspect one? What kind of imaging is typically used?
Vascular imaging is really crucial here. CT scans, often with the injection of intravenous contrast dye.
VTAs.
Right, CT angiography. That's usually the preferred way to look for infections involving grafts deeper in the body, like in the abdomen and chest. The CT can show signs like fluid collections around the graft, gas bubbles, or sometimes disruption of the graft itself.
And for grafts in the arms or legs.
Ultrasound can be especially helpful for infections and grafts located more superficially in the extremities. It's good at distinguishing collections of infected fluid or abscesses from other problems that might cause swelling, like hematomas or pseudoaneurysms, those false bulges in the artery wall near an access site.
And what's the treatment approach for a graft infection? It sounds like a very complex situation with tough choices.
It is extremely complex. The main goals of treatment are twofold. First, to completely eradicate the infection, and second, to maintain adequate blood flow or perfusion to the tissues that the graft was originally meant to supply, like the leg or brain.
Eradicate infection, maintain perfusion.
Okay. Treatment options generally fall into a few categories. One is complete surgical removal or excision of the entire infected graft, followed by creating a new bypass in a completely different, uninfected location in the body, what we call an extra anatomic bypass.
Rerouting the plumbing somewhere else.
Exactly. Another approach is in situ replacement, meaning replacing the infected graft right there in its original position, but using a new graft that's hopefully resistant to infection.
What kind of grafts are used for that?
Options include using standard grafts soaked in antibiotics, special grafts coated with silver, which has antimicrobial properties, or using cryopreserved arterial allografts arteries from deceased human donors that have been specially treated and frozen.
Wow. Are there other options besides replacing it?
In some, perhaps less severe or localized infections, doctors might attempt graft preservation. This involves aggressive surgical cleaning or debridement of the infected tissue around the graft, placing antibiotic-releasing beads locally, and covering the area with healthy tissue flaps, like muscle or omentum tissue from the abdomen. This is usually combined with long-term antibiotics.
Does it work? saving the graft.
It can sometimes, but the risk of the infection coming back is generally higher than with graft removal. Each of these approaches, excision with extra anatomic bypass, in situ replacement, graft preservation, has different potential outcomes. We're talking about risks of death, the possibility of losing a limb, the chance of recurrent infection, and long-term graft patency. The best treatment really depends on the specific details, the location of the graft, the type of bacteria, the extent of infection, and the patient's overall health and ability to tolerate major surgery. It often requires a multidisciplinary team approach.
Okay, let's move to another challenging complication. Secondary aortoenteric fistulas. This sounds rare, but incredibly serious. What exactly is it?
It is indeed a very serious, often life-threatening condition. Secondary aortoenteric fistulas, or AEFs, are actually more common than primary AEFs, which are fistulas that occur in people who haven't had previous aortic surgery.
So secondary means it happens after a prior surgery.
Exactly. Secondary AEFs typically develop in patients who have had prior open aortic surgery, usually with a graft, or sometimes after an endovascular aortic repair, EVR, using a stent graft.
How long after the first surgery?
The average time from the original surgery to the point where symptoms of an AEF appear can be quite variable, but it's often anywhere from 2 to 6 years later, sometimes much longer.
And what is the fistula?
It involves an abnormal connection, a tunnel or fistula forming between the aorta itself, or more commonly the implanted aortic graft, and the gastrointestinal tract, usually the duodenum, the first part of the small intestine that lies right near the aorta.
A direct connection between the main artery and the bowel. That sounds bad.
Extremely bad. It allows intestinal contents and bacteria to get into the bloodstream or onto the graft, causing infection. And it allows high-pressure arterial blood to pour into the bowel, causing massive gastrointestinal bleeding.
And it doesn't always happen right at the site where the graft was sewn onto the original artery.
That's correct. It can be a direct connection right at the suture line where the graft was attached, which we technically call a graft enteric fistula. Or it can be an erosion of the graft material itself through the bowel wall at a point away from the original connection that's known as a graft enteric erosion. Both are types of AEF and are very dangerous.
What causes this to happen? Is it always infection?
Infection is often thought to be a primary or major contributing cause. Bacteria on the graft can weaken the tissue and promote fistula formation. But other factors likely play a role too. The constant pulsatile pressure of the graft against the adjacent bowel wall can cause mechanical erosion over time. Sometimes, a disruption at the suture line can lead to a small leak or pseudoaneurysm, which then erodes into the bowel.
And you mentioned it can happen after endovascular repair, EVAR too. How does that happen with a stent graft inside the vessel?
Yes, unfortunately, AEFs are also being seen after EVAR and KEVAR, thoracic endovascular repair. The proposed mechanisms might be slightly different. Things like persistent leaks around the stent graft, called endoleaks, might create pressure that erodes the aortic wall. The stent graft itself, especially if oversized or kinked, could potentially erode directly through the aortic wall and into adjacent structures like the esophagus or bowel. Pre-existing infection at the time of the EVAR might also be a factor. There was a study called Medifisto that looked into this.
What are the telltale signs that someone might have a secondary AEF? How does it present?
A classic, though not universal, warning sign is what we call a herald bleed.
Herald bleed, like a warning shot.
Exactly. This is often a small, sometimes seemingly minor episode of gastrointestinal bleeding, maybe vomiting blood or having blood in the stool. It might even stop on its own for a period.
Okay.
However, this herald bleed is usually followed, maybe hours or days later, by a much larger, catastrophic, potentially life-threatening hemorrhage if the underlying AEF isn't diagnosed and treated urgently.
So that initial smaller bleed is critical to recognize.
Absolutely crucial. Because of this pattern, it's vital for doctors to maintain a very high level of suspicion for AEF. If any patient with a history of any type of aortic surgery or repair presents with any gastrointestinal bleeding, no matter how small it seems initially.
How are these fistulas diagnosed then? What kind of tests are needed, especially if the patient is actively bleeding?
If the patient is unstable and bleeding heavily, diagnosis and treatment might happen simultaneously in the operating room. But in patients who are stable, or after initial stabilization, a CT scan with intravenous contrast, the CTA, again, is often the first and preferred diagnostic test.
What does the CT show?
It might show air bubbles around the aortic graft where there shouldn't be any, thickening of the bowel wall adjacent to the graft, loss of the normal tissue plane between the graft and the bowel, or even active contrast leaking into the bowel lumen, though sometimes the findings can be subtle.
What about endoscopy? looking with a camera.
Yes, an upper endoscopy, EGD, is usually performed. Its main role is often to rule out other common sources of upper GI bleeding, like ulcers or varices. However, it can sometimes directly visualize the fistula opening in the duodenum or see the graft material itself eroding through the bowel wall. It's particularly important to try and visualize the third and fourth portions of the duodenum, which is distal, further down, as this is where these fistulas often occur.
And angiography, the dye test in the vessels.
Angiography is less likely to directly show the fistula itself, as the bleeding might be intermittent. But it can be very useful for planning the surgical repair, showing the anatomy of the remaining vessels and potential options for bypass.
Okay, so diagnosis is made. What are the operative choices for treating a secondary AEF? It sounds like a really challenging surgical situation with high stakes.
It is indeed one of the most challenging situations in vascular surgery. The mortality rate is high, regardless of the approach. The main surgical options involve trying to achieve those two goals: control the hemorrhage and eradicate the source of infection fistula while maintaining blood flow to the lower body.
What are the main strategies?
Broadly, the approaches include 1. Completely removing the infected aortic graft and oversewing the remaining native aortic stump. Then performing an extra anatomic bypass, usually from the axillary artery in the armpit down to the femoral arteries in the legs, routing the new grafts through clean tissue planes.
Ax-Fem bypass.
Right, axillobifemoral bypass is common. 2. In situ replacement, as we discussed for graft infection. Removing the infected graft and replacing it right there with a new conduit, maybe an antibiotic-soaked Dacron graft, a cryopreserved human artery allograft, or sometimes using the patient's own femoral veins harvested from the legs to reconstruct the aorta and iliac arteries, a procedure called the neo-artoiliac system, or NAS.
Using your own veins to build a new aorta.
Wow. It's a complex but durable option in experienced hands. 3. Sometimes graft excision alone might be considered in very high-risk patients, but this carries a very high risk of limb loss. 4. Endovascular repair has been attempted, usually as a bridge to definitive surgery or in patients deemed too unfit for open repair. This involves placing covered stents inside the aorta to seal off the fistula opening.
Let's talk about the first option, graft excision and extra anatomic bypass. That seems like a standard approach.
It has been a traditional mainstay. The idea is to completely remove the infected source and restore flow through clean tissue planes. However, it's a huge operation, often requiring separate abdominal and chest groin incisions, and it carries its own significant risks,
Such as
infection of the new extra anatomic bypass grafts, which can happen. And a particularly feared complication is late rupture of the oversewn native aortic stump. The remaining bit of aorta can blow out weeks or months later, which is often fatal. Long-term patency of Ax-Fem grafts can also be lower than aortic grafts.
Okay. What about the in-situ replacement options, replacing the graft right there?
This approach is gaining favor in many centers. It avoids the aortic stump blowout risk and potentially offers better long-term patency. It's successful. Using cryopreserved allografts or autogenous vein, NAIS, might offer better resistance to recurrent infection compared to synthetic grafts, although the evidence is still evolving. It's also a very demanding operation.
And endovascular repair for AEF, placing stents.
This is generally controversial for definitive treatment. While it can offer a rapid way to control acute hemorrhage in an unstable patient, it fundamentally violates the surgical principle of removing infected material.
Leaves the infected graft in place.
Exactly. So the rates of persistent or recurrent infection, sepsis, further bleeding, and mortality are very high with endovascular repair alone for AEF. It's generally considered a temporary damage control measure or a palliative option for patients who absolutely cannot tolerate open surgery, and it must be combined with long-term, often lifelong, antibiotic therapy.
Wow. Okay, shifting gears slightly, but still related to interventions. Let's talk about complications that can happen right at the access site, where catheters or instruments enter the artery, usually the groin.
Right. Access site complications are unfortunately quite common, especially with the increasing number of endovascular procedures being done. The femoral artery in the groin is the workhorse access site.
What's the most common issue? Bleeding.
Bleeding and hematoma formation are definitely up there. A hematoma is just a collection of blood outside the vessel. It can happen if access was difficult, if multiple attempts were needed, or if closure of the puncture site wasn't adequate.
How big can they get?
They can range from small bruises to very large collections that cause pain, compress nerves, or even require surgical evacuation. Using ultrasound guidance for initial access can potentially help reduce the risk by ensuring clean entry into the artery.
What about bleeding that goes
So,
backwards into the abdomen?
that's a retroperitoneal hematoma. It happens if the puncture in the femoral artery is too high, above the inguinal ligament. Blood tracks back up into the space behind the abdominal cavity.
Is that serious?
It can be very serious, even life-threatening, because a large volume of blood can accumulate there before it becomes obvious. It often presents with back or flank pain, a drop in blood pressure, and requires urgent diagnosis, usually with CT and management, which might include resuscitation, stopping anticoagulation, and sometimes intervention to stop the bleeding.
Okay. What else can happen at the groin access site?
You can get an arteriovenous fistula, or AVF. That's an abnormal connection between the femoral artery and the adjacent femoral vein, usually caused by the needle passing through both vessels during access.
A hole between the artery and vein.
Exactly. It's relatively rare. Small ones might close on their own, but larger ones can cause leg swelling or high-output heart failure and usually require treatment, often with a covered stent or sometimes surgery.
And pseudoaneurysms, you mentioned those earlier.
Yes, a pseudoaneurysm or false aneurysm is another common access site complication. It's basically a contained rupture of the artery where blood leaks out but is held in by the surrounding tissues, forming a pulsating sac that communicates with the artery.
So it feels like a pulsating lump.
Exactly. You often feel a pulsatile mass and might hear a bruit, a whooshing sound with a stethoscope. Diagnosis is usually confirmed with ultrasound.
How are they treated?
Small ones might clot off on their own with observation. Larger or symptomatic ones often require treatment. Options include ultrasound-guided compression to try and thrombose the neck of the sac, ultrasound-guided thrombin injection directly into the sac to clot it off.
Injecting clot-forming medicine.
Yes, that's very effective for many. Or, if those fail or aren't suitable, surgical repair is needed to close the hole in the artery.
What about accessing arteries in the arm, like for heart caths or sometimes peripheral work?
Upper extremity access, usually the brachial artery in the upper arm or sometimes the axillary artery near the shoulder, has its own set of potential complications. Injury to the artery itself, thrombosis, clotting off the artery, or nerve injury are risks.
Nerve injury in the arm?
Yes, the brachial artery runs very close to the median nerve, so nerve injury is a specific concern with brachial access. Thrombosis is also more common than in the femoral artery because the vessel is smaller. Patients might present with pain, numbness, weakness, or a cool, pale hand. Prompt recognition and treatment are key.
And radial artery access in the wrist. That's become really common for heart procedures.
Yes, radial access is much more common now, largely because it has lower rates of major bleeding complications compared to femoral access, and patients can often walk sooner.
But it still has risks.
It does. The main risk is radial artery occlusion, where the artery clots off after the procedure. Usually the hand has dual blood supply from the ulnar artery, so it doesn't cause major problems, but it can sometimes cause hand pain or preclude using that artery again. Hematomas can occur. Nerve injury is rare. Compartment syndrome in the forearm is a very rare but serious complication.
Okay. And even accessing arteries in the foot, pedal access.
Yes, sometimes for complex leg interventions, access is obtained in the arteries of the foot, like the tibial arteries. This also carries risks of bleeding, hematoma, vessel occlusion, and potential damage to small nerves or tendons in the foot.
You mentioned inadequate closure. What about the devices used to close the artery puncture site? Vascular closure devices, or VCDs.
Right. VCDs were developed to achieve faster hemostasis, or stopping bleeding, compared to traditional manual compression, allowing patients to get up and move around sooner.
Sounds good. Are they used all the time?
They're used frequently, but not universally. There are different types, and they work in different ways. Some use sutures to stitch the hole closed, like Perclose. Some use staples or clips, like Starclose. Some use plugs placed on the outside, like Exaseal or Minx Grip, or inside the artery, like Angioseal.
Do they have their own complications?
They do. While they aim to reduce bleeding, bleeding complications can still occur, sometimes related to device failure or deployment issues. More specific VCD complications include infection, arterial occlusion if the device blocks the vessel, embolization if a part breaks off, and sometimes inflammatory reactions. Each device type has its own specific potential failure modes and complications that operators need to be aware of.
So maybe not always better than just holding pressure.
It's debated. For many routine cases, they offer convenience. But in complex access situations, or if there's vessel disease at the puncture site, manual compression might still be preferred by some.
Okay. Beyond the access site itself, What about complications related to the endovascular procedures themselves? The balloons, stents, atherectomy devices.
Right. The intervention itself carries risks. One common issue during balloon angioplasty or stenting is dissection.
Dissection. Like a tear in the artery wall.
Exactly. The balloon or stent can create a tear in the inner lining of the artery, the intima. This creates a flap that can block blood flow.
What does that look like on the angiogram?
You might see a thin line within the vessel lumen, contrast staining within the vessel wall, or impaired flow downstream.
How is it treated?
Minor dissections might heal on their own. More significant ones, especially if they limit flow, often require treatment. Prolonged balloon inflation across the dissected segment can sometimes tack the flap back down. Often, placing a stent across the dissection is needed to scaffold the vessel open and seal the tear. Sometimes atherectomy devices, which remove plaque, can actually cause dissection too.
What about subintimal angioplasty? That sounds like intentionally creating a dissection.
It is. Subintimal angioplasty is a specific technique used mainly to cross long, chronic total occlusions, completely blocked arteries, usually in the leg.
How does this work?
The idea is to intentionally guide a wire under the plaque into the space between the inner lining and the middle layer media of the artery wall, creating a channel alongside the blockage. Then you re-enter the true lumen of the vessel further downstream beyond the occlusion.
And then balloon that channel.
Yes, you balloon that subintimal channel open. It's a way to recanalize arteries that are otherwise very difficult to cross directly through the plaque. Success depends critically on being able to get back into the true vessel lumen distally.
What about stuff breaking off and traveling downstream? Embolization.
Embolization is probably one of the most feared complications of peripheral endovascular interventions. It's when plaque debris or blood clot breaks loose during the procedure and travels downstream, blocking smaller vessels.
Where's the risk highest?
The risk is higher in heavily calcified or ulcerated plaque when treating long blockages if there's visible thrombus clot present, or when using certain devices like atherectomy devices that actively remove plaque.
What happens if it embolizes?
It can be devastating, especially if it goes to the foot, causing acute limb ischemia, sudden loss of blood flow, often called trash foot, if it's multiple small emboli. It requires immediate attempts to remove the emboli, often with aspiration catheters or further intervention. Sometimes embolic protection devices, like filters placed downstream during the procedure, are used in high-risk cases to try and catch debris.
What about the access vessel itself rupturing during a procedure like EVR, endovascular aneurysm repair?
Access vessel rupture, usually the iliac artery used to introduce the large EVR delivery system, is a rare but potentially catastrophic complication.
How is it managed?
Immediate control of bleeding is paramount. This usually involves inflating an occlusion balloon proximal to the rupture site to stop inflow. Then the rupture is typically treated by deploying a covered stent across the tear to seal it from the inside. Occasionally, open surgical repair might be necessary if endovascular methods fail or aren't feasible.
Okay. And complications related to thrombolytic therapy, using clot-busting drugs.
Thrombolysis, infusing drugs like TPA directly into a clotted artery or bypass graft, is used to dissolve thrombus. The major complication, unsurprisingly, is bleeding.
Where does the bleeding occur?
It can occur anywhere, most commonly at the access site. But more serious bleeding can happen internally, like intracranial hemorrhage, bleeding in the brain, the most feared complication, or gastrointestinal bleeding. Careful patient selection, monitoring of clotting parameters, and adjusting the dose are crucial to minimize risk. If significant bleeding occurs, the infusion needs to be stopped, and sometimes reversal agents are given.
Lastly, in this category, what about IVC filters? Those devices placed in the big vein to catch clots from the legs.
Inferior vena cava, or IVC, filters are used to prevent pulmonary embolism in patients with deep vein thrombosis, DVT, who can't take anticoagulants. While they can be life-saving, they have their own potential complications. The filter itself can thrombose or clot off, paradoxically increasing the risk of leg clots or causing IVC occlusion. Filters can migrate from their original position, either up towards the heart or down. Parts of the filter can fracture, or the struts of the filter can perforate or erode through the wall of the vena cava, potentially injuring adjacent structures. That's why many filters placed now are designed to be potentially retrievable, although retrieval isn't always possible or successful.
Okay, one last category of potential complications, lymphatic issues. This isn't something you always think about with vascular surgery.
That's true, but lymphatic complications can certainly occur, especially after surgery in the groin or involving extensive dissection around major vessels where lymphatic channels run.
What's the most common issue? Leg swelling.
Postoperative edema or leg swelling is very common after lower limb arterial reconstruction, like a femoral bypass. It's often multifactorial. There's a lymphatic component, as surgery can disrupt lymphatic drainage channels. There can also be a venous component, maybe related to inflammation or temporary venous hypertension after restoring arterial flow.
Does it usually get better?
It often improves over time, but persistent lymphedema can be a chronic issue for some patients. Compression therapy is usually the mainstay of management.
What about specific lymphatic fluid collections?
You can get a lymphocell. That's a collection of lymphatic fluid that accumulates in the surgical wound bed, usually in the groin after procedures there.
Like a fluid-filled lump.
Exactly. It typically appears a week or two after surgery. Diagnosis is usually by ultrasound or CT.
How is it treated?
Small, asymptomatic lymphocillas might resolve on their own with observation. Larger or symptomatic ones might require aspiration, draining with a needle, though they often recur. Sometimes injecting sclerosing agents to make the walls stick together is tried. Persistent or infected lymphocilles might need surgical drainage, excision of the sac lining, placement of a wound VAC, vacuum-assisted closure device, or rarely complex procedures like lymphovenous anastomosis to redirect lymphatic flow.
What if the lymphatic fluid just keeps leaking out of the wound?
Oh.
A lymphatic fistula.
A lymphatic fistula or leak is characterized by persistent drainage of clear, yellowish lymphatic fluid from the surgical incision, again, most commonly in the groin. It can be quite prolonged and bothersome, increasing infection risk.
How do you diagnose that for sure?
Sometimes a special imaging test called lymphoscintigraphy is used, where a tracer is injected into the foot to map the lymphatic channels and identify the leak site.
And treatment.
Management often starts with conservative measures like meticulous wound care, compression dressings, and sometimes medications to reduce lymphatic flow. If it persists, surgical exploration with ligation, tying off of the leaking lymphatic channels, might be necessary. Wound VAC therapy can also be helpful.
What about lymphatic problems inside the body cavities? Chyloscytes.
Chyloscytes is the accumulation of lymphatic fluid, specifically chyle, which is rich in fats absorbed from the intestine, within the peritoneal cavity, the abdomen.
What causes that after vascular surgery?
It's most commonly seen after extensive aortic surgery, especially involving dissection around the cisterna chyli or major lymphatic channels near the aorta, causing them to leak.
How is it diagnosed?
Diagnosis is usually made by sampling the abdominal fluid via paracentesis, inserting a needle, and analyzing it. Chylous fluid typically looks milky and has high triglyceride levels.
And treatment?
Management often starts conservatively with dietary changes, low-fat diet, medium-chain triglycerides, sometimes medications like octreotide to reduce lymphatic flow, and repeated paracentesis to relieve symptoms. If that fails, surgical options like ligation of the leaking duct or creating a peritoneovenous shunt to drain the fluid into the venous system might be considered.
And chylothorax. Same idea, but in the chest.
Exactly. Chylothorax is the accumulation of chyle in the pleural space, around the lungs.
How does that happen?
It usually results from injury to the thoracic duct, the main lymphatic channel that runs up through the chest, often during surgeries involving the aorta or esophagus in the chest.
Diagnosis and treatment similar.
Diagnosis is confirmed by analyzing fluid removed via thoracentesis, needle aspiration from the chest, again, looking for high triglyceride levels. Management is similar to chyloscytes. Conservative measures first. Chest tube drainage, dietary modification, octreotide. If the leak persists, surgical ligation of the thoracic duct, often via minimally invasive thoracoscopy, is usually effective.
This has been an incredibly comprehensive look at the potential complications after vascular surgery. It's really clear that while these procedures can be life-saving, there's a lot that both patients and, medical professionals need to be aware of. So many interconnected systems.
That's exactly the key takeaway.
Yeah.
Vascular surgery, by its nature, has these wide-ranging effects on the body. And a solid understanding of these potential complications, cardiac, renal, neurological, graft-related, infectious, lymphatic, it's vital for anyone involved in the care of these patients or for patients themselves trying to understand the risks.
Right. And this deep dive has really given us, I think, a structured and insightful overview of these complex issues, drawing directly from the knowledge of leading experts in the field via Rutherford's text.
Absolutely. But it's important to remember, isn't it, that each of the areas we've discussed today, MSC, AKI, nerve injury, AEF, They really deserve even more detailed exploration on their own.
Oh, for sure. Hours in each one.
Easily. So we really encourage you, the listener, to seek out further information based on whatever specific aspects have piqued your interest or might be relevant to your particular needs or situation.
Definitely. So as we bring this deep dive to a close, let's maybe consider this. With all the continuous advancements we're seeing, and surgical techniques, minimally invasive approaches, the materials used for grafts, better imaging, better meds, the ways we care for patients after surgery, all aimed at reducing these risks and improving outcomes. What exciting future innovations do you think might further revolutionize the field of vascular surgery and minimize these potential complications even more? It's definitely a fascinating question to ponder, isn't it?